Now, I think we have been talking about it, two major areas of controversy, which I think most of us, including even the psychiatrists which we have, is that a lot of times we wonder: are we dealing with a depressive disorder, or is it sort of a mild, more severe normal sadness? This is the problem. When it's a problem like the normal sadness, you don't treat with the medication. Depressive disorder, you have to treat with medication. Second thing is that generally depression, even in the lay public, it's mostly the depression is psychological. What are they doing with the pharmacotherapy? This is where the lack of conviction. Depression as a disorder, whatever may be the causative factors for depression, the final common causative pathway being serotonergic dysfunction is the most important thing which we all have to understand. As somebody said, myocardial infarction, whatever may be the causative factor, ultimately, in addition to the whatever CIBGs, you give aspirin because it's the clot mechanism of that which has to be taken care. That is, whatever may be the psychological or biological or some other factors in them, final common pathway is serotonergic dysfunction, and this your drugs SSRIs work in correcting the serotonergic dysfunction, and that is where you need to have the conviction in giving SSRIs to the management of depression, which sometimes is lacking. Now, after this, right, as I told you, I'm a little bit passionate about this particular subject. Today, I have come to you with almost like kind of ambitious kind of a program, and then there are lots of 1, 2, 3, 4, 5, 6. There are so many points which I thought I'll discuss with you and then share my ideas with you. That is where I'm coming. I'm going to list out all those things. Maybe all those things today will not be discussing. Maybe something we will discuss in the next session also. Combat depression, what are the barriers? I already told conceptual clarity, whether it is diagnosis and pharmacotherapy. Do we have the clarity and then certainty about it? We need to have it because it's urgent now. We cannot delay it further because there's a gap of 80%, 85%, which has been shown not only in India, all over the world. All the studies, WHO has done almost a 60 nation survey. Even this also, this kind of it's like it may vary from 70 to 80%, but it's been there. Now, these are the points which I thought today I'll be discussing. One is about pharmacotherapy. What is the effectiveness, treatability? Is it applicable, replicable, affordable, and accessible? What is the role of telemedicine? Then, a few points which mostly I think most of you would have not bothered. We generally use Hamilton Depression Rating Scale 17. Why are we not using HAMD 21? Why are we using only 17? I'll discuss about it later. Then NICE guidelines, this also, HAMD 17, a difference of 3 is enough to differentiate between an active drug and a placebo. I'll talk about it later. The most important thing, improve drug compliance. The one point which I felt in study is that considering the high dropout, high attrition rate, the one of the main reasons I felt is that very poor compliance when it comes to the medication, and that is the reason why we had that very very low remission rates of 30%. Because it's not in RCTs. What happens is that randomized control trials, it's a control trial for about 6 weeks or 8 weeks. The patient is very closely followed, and every time the patient comes back after a week or 2 weeks, the drug count is done, how many times it is missed, what is done, everything is recorded, and the very systematic evaluation of the compliance is taken care of, which I think did not happen in study. Patient was given the medication, patient went home. Every 2 weeks, it's a telephone call, and only after 2 months. In these 2 months, whether the patients have taken the medication or not, how much is the compliance is a big problem here, and this is the problem. I think that is where the translation is not happening. RCTs have shown us that escitalopram is a good drug, it's an effective drug, it's very effective in the management of MDD. The study has shown us that it's effective only in 1/3 of the patients. The difference, I think, is in the compliance. This is what I see in the clinic also. Then how do I improve the compliance? This is going to be the very, very important thing, where I thought that today I will discuss with you this DOT, direct observational treatment model, which they have used in the management of tuberculosis. Again, you may wonder, what is the tuberculosis model you are trying to talk about in MDD? Let me see, I'll discuss with you this DOT model to improve the compliance. Diagnosis, prognosis, I'm going to discuss this. Under treatment, this is the one thing which I always felt that We are over-diagnosing and then over-treating bipolar disorder, and then under-treatment. We are not treating major depressive disorder effectively to the way it has to be done. And then constructability of the diagnosis, both cross-sectional, longitudinal, and discuss subtypes and suicides in MDD. What is happening in the last half a century? Like, is there a decrease? Why is that there is a more suicidal attempts in the females and then more suicidal deaths in case of males? Why? What could be the reasons? And then the major depressive episode in bipolar disorder. One, bipolar disorder. Two, what is that? How do we manage that? What is the presentations? And then postpartum depressions. And then PMDD, premenstrual. Natural course of DD. What does it tell us? Like a natural course being complete recovery. What could we think about the etiological guess about it? That, and lastly about psychotherapy and all. And I know that some of you may be a little bit too worried that there are too many things for discussion, all the things, how long it's going to go. No, 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 I'm not going to discuss the whole thing today. Maybe let me see to whatever extent I can discuss today, and then rest of the things we can do it in the later. But these are the few. As I told that I came to you today with a very ambitious agenda, and let me see what we can discuss. This is what I told about the concept has to be clear. When a patient presents to us, what we, as to any doctor, what we are supposed to be doing is that get him into the asymptomatic state. That's it. Whether it is fever or a leg pain or a backache or depression or this is what we are supposed to be doing as a medical doctor, and you do it by providing some treatment. And then how do you arrive at the what kind of treatment you get? It is by making a diagnosis. And then this is with the classificatory system. And this is the most important thing. The concept of this particular illness is going to be the most important thing. This is what I say that almost about 100 years ago, the concept mood disorders and the thought disorders has been classified, and then this is where it's, unless your concept about MBD is very clear and then with some kind of a conviction, it's always difficult to proceed down the lane. That is what is the problem, and I think this is where we need to have a clear-cut concepts about what is the diagnosis we are dealing with and what is the medication we are doing about. Right, what are the therapeutic goals? This is what we all know, that in the recovery from MDD, this one MD, the score is less than 7, and then global assessment function more than 80. This is, and then preventing suicidal mortality is very, very important. These are the two important therapeutic goals when we see a patient with major depressive disorder. And then preventing the future episodes, it's always there to what extent, but to what extent we can do is going to be the problem. Natural course of mood disorder is recovery. I've been talking about it repeatedly again and again and again. Recurrence is seen in some. When it is a natural course, is like in a recovery. What are we doing? We are only facilitating this morbidity reduction, mortality prevention. We are trying to facilitate that. We are trying to shorten the duration of it and trying to do that. Tricyclics were good drugs. Tricyclics are very effective, but there's a risk of adverse events. Significant and both serious. I talk about adverse event in both the sense. Very significant anticholinergic side effects where they had a lot of dryness, constipation, and then with hypertension problems. And then I've seen patients with paralytic illness. Serious is cardiac morbidity. Sometimes you see with. So SSRIs are the safe drugs which have replaced tricyclics and then now rule the domain with the promise of recovery in depressive disorder. Now here I think we have to look at these 5. Do they satisfy this? Are the SSRIs effective drugs? Yes, definitely. I don't think there's any doubt about it, even though study has put a query on that, but SSRIs are effective. Is it applicable? Can we take it like an SSRI for the MDD? Can we take it on a broader? Yes. Replicable in a broad scenario in the community. Can we replicate this, whatever the use of SSRI? It's a simple treatment. Yes, definitely we can. Affordable. Today, at least in India, Western countries, maybe it's costly. In India, escitalopram costs about 10 rupees or 12 rupees per month. It's about 400 rupees, not more than that. 20 milligrams of escitalopram is a very good drug, very efficient drug in the management of depression. There's no doubt about it. It's very affordable. And then, one tablet a day, it can be very well. In the community, it can be practiced. Replicable is accessible, right? When it comes to this limited number of psychiatrists and not like a huge population, that is where the last mile, that is where I feel that teleconsultations can help in accessing the last mile. This is going to be the future. I think this is going to be the very important. Teleconsultation also, I think, is going to do a lot in reducing the stigma. Stigma is one of the problems where people do not approach a psychiatrist. I think teleconsultation is going to solve this to a large extent. So when you look at the treatment, antidepressant treatment, they are effective. This is applicable, and then we can replicate in the community. It's affordable and accessible. With this kind of a conviction should be there when we talk about the management of major depressive disorder. That is what I thought I'll put it here. Now, right, this is mainly to see that if you have one episode, when a patient has one episode of MDD, the chance of next episode is 50%. So that means that 50% of the patients do not have the second episode. So it is quite, that's where we can talk about recovery. 40 to 50% may not have the second episode in their lifetime itself, so which is excellent. So one episode is only, but when it have a two episode, the risk of recurrence shoots up to 80, 90. Three episodes, almost. Once a patient has three episodes, there's a very high chance of them having more and more episodes in the future. That is going to be the thing which can happen. But this is one thing which I say, that almost about 40% of the patients may not have the second episode. I think last time also I was showing it, when the natural course of the thing is that recovery, why do we have to do, what are we doing, is that this is the difference here. In the natural course, patient recovers, but this much of a time he takes. With our intervention, he comes to this level faster. Reduce the time of term duration of the illness, reduce the morbidity, and in the process also prevent the mortality by suicide. This is a beautiful a point here, that this is a data from the Northwest Wales Asylum. This is in UK. See here the data comparison. This is mainly regarding the bipolar disorder, and then that's what a bit I have taken. Bipolar disorders, where we talk about mood disorders, prognosis is better, good. This period, if you look at 1875 to 1924, and the compared with 1994 to 2005, average length of hospital stay for one episode, 6 months here, 1 month. But this is important here. Almost all patients went home well. Even about 150 years back, 100 years back, without any pharmacotherapy, without anything, natural course being that patients went home. This is what happens in mood disorders. But the thing was, the suffering, the illness duration was 6 months, which led current psychopharmacology has brought down to 1 month, which is a significant achievement. I feel it's a significant achievement, and then the credit goes mostly to pharmacotherapy. Of course, people say that the psychosocial factors have improved. There are a lot of addition to that. There's a lot of contribution from the family understanding, society understanding, and the kind of support what they're getting. Yes, but the major contribution is to this is from the pharmacotherapy. This has been substantially reduced. This is one of our great achievements when it comes to the management of mood disorders. We are able to successfully, very clearly, control the length of the episode, and thereby reduce the morbidity. Depression morbidity is one of the very high compared to majority of the physical illnesses, which I think we all know about it. Now, again, this is a similar kind of a thing I just want to show here. The acute episode, and then comes out of the acute episode here, the remission you call it, and then you go on to that recovery. Remission, that is, patient becomes asymptomatic. You say that the HAM-D is less than 7. But now, at this point, it's not called recovery. Sustained remission for at least 8 to 12 weeks period. Here it is remission. Only when it is continued for 8 to 12 weeks, then it becomes recovery, and then the recurrence. But this difference has been, whatever the reason, it has been removed from CanMat 2018. I do not know what is the reason that's been removed. So if you follow CanMat 2018, there is nothing like a remission here. At this point itself, you can call it a recovery. But now I don't know what will be the implications. But we all thought that this is the point, and then this is natural course of illness, where we talk about continuation phase. Continuation phase is another peculiar thing for psychiatric